This work is focused on data sharing and interoperability between jail and community health systems. So we'll start with a brief introduction of jail health systems and the problem of interoperability. Interoperability between jail health systems and local community health systems is a widespread problem among counties across the United States. The jail health systems provide healthcare services to thousands of incarcerated individuals and are oftentimes the only source of healthcare for this population. So providing continuity of care and linking inmates to appropriate providers in the community demands for an efficient and a meaningful way to share data between various systems. So the goal of this work is to examine methodologies used by counties across the country to increase interoperability between the jail system and the community in an effort to improve coordination of care. So there are three main systems involved in interoperability in this particular context. One is the jail management systems, second is the jail health system, and the third is the community health system. So we'll first describe the jail management system, which comprises of critical data that is needed to operate the correctional facilities. So this would include inmates' calendar, that includes court dates, medical appointments, bunking assignments, inmates' housing location, and case management notes. And then we have the jail health system, which is essentially the inmates' health record system needed to provide healthcare to the inmates' population within the jail facility. So this would include inmates' medication administration data, laboratory orders and results, and treatment records. Jail health record systems are electronic in few sites, but the vast majority of jail sites across the United States are still using paper records of some form. And then lastly, we have the community health systems that are external to the overall jail system. And the community health system is used by external providers to coordinate care for inmates after their release from custody. So these are the three main systems, and we are going to present a few examples and methodologies that promote interoperability and data sharing across these three systems.
Okay, thank you. So we examined a few counties across the country who have taken initiatives to bridge the gaps of communication between these systems and develop robust programs of data exchange. So we looked at Orange County in Florida, Multnomah County in Oregon, and New York City in New York. So in the context and rationale for interoperability, the mental health and substance abuse crisis within Orange County, California served as an impetus to change initiatives within the community and the correctional health system. The county as a whole saw a significant increase in homelessness, psychiatric hospitalization, and increase in hospitalizations related to substance abuse. So just to give you a little insight into the data that was gathered, 40% of the individuals incarcerated at Orange County jails stayed only 7 days or less, and 70% of individuals stayed 29 days or less. 21% of them were diagnosed with a mental illness, 40% were diagnosed with substance use disorder, 10% were considered co-occurring, having both a mental illness and a substance use disorder. And there are consistently about 1,800 inmates receiving mental health services from some kind throughout the year. And lastly, 5% of the jail population were considered high utilizers. So this data suggests a significant need for improved continuity of care when leaving custody, re-entering back into the community. The lack of connection between the providers inside the jails and the providers in the community have contributed to the increase in recidivism. In Orange County, there are three systems that make up the jail management system, jail health system, and community health system. So adult jail system, or AJS, serves to track inmate housing and movement. In addition to tracking housing locations, the system tracks pending court dates, sentence ending dates, and past and current charges. Tech Care, an EHR system specifically designed to meet the needs of correctional facilities. It connects to all critical elements, including the jail management system, laboratory system, pharmacy, diagnostics, food services, hospitals, and insurance providers like Medicaid. Additionally, it allows for maintaining inmates' history of care while also supporting charting and litigation activities. Lastly, there is Integrated Records Information System, or IRIS. It's used by both public health and behavioral health services for scheduling appointments, writing and tracking prescription, messaging between providers, billing, and documentation of the patient's health record. IRIS also facilitates sharing of medical, mental health, public health, and substance use disorder data between Orange County community health providers. So this is the communication between AJS and TechCare. So with interface, both systems sync and communicate every 10 minutes to track housing changes and movement. For the purposes of exchanging information about court dates and sentence ending dates, both systems sync daily in the evening hours after courts conclude. Although this change is not in real time, the frequency of interface keep the case managers relatively informed about reentry dates. There is a value in this data exchange. So anticipating an inmate's date of reentry is crucial for jail healthcare staff to ensure continuity of care and a warm handoff takes place to a community provider. This can mean the difference between accessing much needed care and reincarceration. There are some current limitations between Orange County's data exchange between the two systems. At this point, data shared from the jail management system to the jail health system is not the other way around. Part of the reason is that the jail management system does not have the technical capabilities to manage the volume of data that the jail health system would share. This leads to missed opportunities to share physical disabilities, medical accommodations, dietary restrictions, and medical risks. This information is sometimes crucial for security staff to be aware of and maintain safety with the inmate population. Both systems still utilize paper records for inmate message requests for medical treatment, sick call passes, and American Disability Act accommodations. Not only does this leave more room for human error, but there's a considerable delay in the information that is available to health providers. So this is the communication between TechCare and IRIS. So interface and limitations, the only exchange of information between TechCare and IRIS is with laboratory data. Health service encounters within the jail system are shared with IRIS, but it requires clinicians to do a dual entry of data in both systems. TechCare is able to access medical history data from IRIS, but the information is limited. Currently, jail providers only have access to partial reports, which very much so limits the ability to see the full scope of care they were receiving in the community. In 2019, Orange County Correctional Health Services implemented the Jail to Community Reentry program to increase offender success and post-release integration into the mainstream community. This team is made up of both licensed behavioral health clinicians and data specialists. The objectives of this program is to improve mental health related case management systems, increase re-entering offenders' access to community resources and government assistance programs, increase connection with family and other support systems in the community, utilize evidence-based interventions to address chemical dependence and criminogenic needs, improve interoperability between various entities for coordinated and effective reentry system. The collaboration includes various internal stakeholders such as Orange County Sheriff's Department, along with external stakeholders in the community, including behavioral health service providers, Orange County Probation, the Public Defender's Office, Social Services, Orange County Housing Authority, and other ancillary agencies providing support and community resources. So, reentry outcomes within the first year. The program's success is measured using two sets of outcomes: the quantity of referrals being made to the community and the number of successful linkages. A successful linkage is defined as the patient successfully making initial contact with the community provider and enrolling in their program after being released from custody. Since the start of the program, there was an obvious increase in the quantity of referrals being made from the jails to the community. The quantity of referrals almost doubled for some of the providers in the community. The number took a sharp dive in the month of April 2020, likely due to COVID-19. At the start of the pandemic, the jails drastically decreased their census by about 50% and released thousands of inmates early due to the zero bail policy. The rate of linkage hovered at around 10 to 15%, regardless of the quantity of referrals or the jail census. So the discussion. So there are a few reasons why linkages were failing within the first year. The first was lack of in-reach services. In-reach is where a representative from the community entity makes face-to-face contact with the inmate prior to release and engaging them in services. Not only is this informative for the patient and allows community provider to conduct assessments, but more importantly, begin building relationship with the inmate. This is crucial for the inmate to develop trust. In-reach was limited within the first year because COVID-19 drastically limited the number of external entities from entering the jail facility, and programs sometimes lack the number of staff available to provide the service. Next, we have the inability to provide a warm handoff. A warm handoff is where a representative from the community provider meets with the inmate face-to-face on the day of release. The representative is able to engage the inmate immediately in services and facilitate transportation to their program. Many of our inmates are homeless, lack social support, and transportation resources. The first moments of release are essential for capturing the inmate. This could mean the difference between an inmate entering into the continuum of care or recidivating back into the jail system. Lastly, we have a deficit in data sharing with the community. This has limited the clinical staff from accessing their medical and behavioral health history. So essentially, they're going to be going in there blind, with sometimes only relying on what the inmate is telling them. This constantly leads to inappropriate referrals, where inmates are placed in the wrong level of care. This also creates problems with care coordination. For example, if an inmate is already linked to an external provider, it can sometimes require intensive investigative work by the clinician to make the connection. This information should be readily available and not require excessive amount of time to retrieve. So lastly, we have the outcome data. The reentry program requires outcome data for reporting and evaluation purposes. Currently, inmate information is manually entered into a spreadsheet to track releases and referrals. A monthly list of inmate releases is produced and sent to the corresponding community provider. The corresponding community providers manually identify which inmates successfully linked to their programs and which ones did not. This list is then sent back to the reentry program and manually entered onto another tracking spreadsheet. Because of the lack of interoperability between the reentry program and the community, there is extensive room for human error and missing data. So, conclusion: a robust health information exchange program is essential to providing adequate continuity of care and proper care coordination. In order for a county to implement a data exchange program between the community and the correctional facilities, there needs to be champions who believe in the need for interoperability and advocate for the jail integration with the community. These individuals possess the influence and utilize it to drive policy and resources in the direction needed. Then there's bidirectional data sharing. For each system that communicates with another, there needs to be bidirectional communication. When looking at the missed opportunities in Orange County, many of them are related to communication happening only one direction. Patient outcomes. Patient outcomes in relation to the transition process should be shared between the jail system and the community. The best way to measure success and shortcomings is to examine the patient outcomes. Did the inmate receive adequate continuity of care? Did the inmate link to the appropriate care provider in the community? Did the inmate increase or decrease recidivism? These are the questions that are vital for programs to understand if they're hitting the mark or not. Policy. Policy reflecting the interests of interoperability is key because it drives much needed resources to programs that jail integration to occur. These programs are expensive and require personnel. Then we have community stakeholders. The relationships between the jail and key community stakeholders are pertinent in tackling such a large endeavor. Cooperation and coordination between these entities will lay the groundwork for long-term success. Transitions of care can only happen if both programs are on board. And lastly, there needs to be meaningful data. The data should provide continuity of care when transitioning to a new system or provider. It should also inform the providers to assist in accurate and effective care coordination. Important features of meaningful use within the jail EHR system include electronic prescribing, meaningful use performance tracking, providing clinical summaries, and providing patients with the ability to view online, download, and transmit health information. So the community in the jail should be sharing these common clinical data elements, which include psychosocial history, medical and medication history, diagnosis codes, a summary of care for the current provider, assessment of care needs, medication data like active prescriptions, history of care in the community and the jail facilities, lab and imaging results, inmate signed letters, requests, consents, and grievances, and documented transition plans. Thank you for listening to our presentation. Please feel free to reach out to us if you have any suggestions, ideas, or questions, and you can find our contact emails below.